Hi everyone, my name is Michelle Kameda Smith. I'm a PGY5 in neurosurgery here at McMaster, and I'd like to thank you for taking the time to listen to how I navigated a global surgical elective in a growing pandemic in Mbale, Uganda. As for disclosures, I was one of the lucky 2019 to 2020 recipients of the Matt Globus Resident Research Elective Scholarship. The objectives of my talk will be to provide a neurosurgical resident's global health experience in a low-resource setting, as well as to understand the burden of pediatric neurosurgical disease in Uganda, and finally to understand the impact of pediatric neurosurgical care in Uganda and global surgical training during the height of the COVID-19 pandemic. Since very on in my training, I've wanted to become a pediatric neurosurgeon. Dr. Ajani, who's one of our pediatric neurosurgeons here at McMaster University, was also previously a program director. He's from Nigeria and did his neurosurgical residency in South Africa. And having never been to Africa and being interested in doing an international elective in pediatric neurosurgery, I asked Dr. Ajani whether we can organize an elective either in Nigeria or South Africa. Initially, there's plans for South Africa, but then last year he had proposed going to Uganda to Cure Hospital, which is quite famous in and of itself. When it was first mentioned that I would be going to Uganda as a possibility for my neurosurgical elective, I was very anxious, and mainly this was because I had watched a movie back in the early 2000s called The Last King of Scotland, and this was...
Place you land, you go. First place you land, you go. How many doctors do you have here?
Well, there's me, and now there's you.
You seem an unlikely candidate for this kind of work.
I don't want to make a difference, Sean.
I may wear the uniform of a general, but in my heart, I am a simple man. I am you.
What's going on?
The president wants to see you now. You are British.
I'm Scottish.
Scottish? Why didn't you say so?
This is the sort of man a president needs around you.
You want me to be your physician?
I want to introduce you to my wife.
What you need is to have some fun.
You have been known to devour your enemies.
Eat my enemies. I eat chicken.
Any idea what's going on in this country? They're not even bothering to dig graves anymore. They're simply feeding them to the crocodiles.
Nicholas, tell me what is on your mind.
I have to go home now.
You cannot. You are like my own son.
I'm Nicholas Garrigan, and I'm from Scotland.
Your home is here.
about a physician going to Uganda. So I decided to look into Cure Uganda. Cure International is a Christian medical missions organization which was founded by Dr. Benjamin Wharf back in 2000. He was the medical director and chief of surgery until 2006, after he had established a new technique to treat infectious hydrocephalus in a low-resource setting. It was the very first pediatric neurosurgical subspecialty teaching hospital in sub-Saharan Africa, and they treated hydrocephalus, neurotube defects, and brain tumors. Through hard work and professional development, Cure Uganda is now fully staffed by Ugandan local neurosurgeons and physicians as well as nurses. And when I looked more into Uganda as a country, back in 2019 when I was doing my research, the president at that time was President Museveni, who had been so since 1986. It is part of East Africa and bordered by Kenya to the east, South Sudan to the north, DRC to the west, and Tanzania to the south. The population is just under 43 million and contains many large lakes. The country lies completely within the Nile Basin, and its rich soils grows coffee beans, tobacco, and tea leaves, with agriculture making up nearly 50% of the country's exports. While it is considered one of the poorest nations in the world, Uganda continues to experience consistent economic growth, and is considered a relatively peaceful nation engaged in UN peacekeeping efforts, mainly within Africa. After looking into flights and the cost of organizing the elective, the financial burden was not going to be insignificant. Dr. Ajani had advised that I apply and compete for the International Surgery Desk Resident Scholarship, which I received in 2019. And this began some of my pre-elective preparation, which was a research proposal to the Ugandan IRAB because I wanted to be involved in research while I was there. I had to obtain a Ugandan medical license so that I can operate while I'm there as well. And also critical to getting into the country was having my yellow fever vaccination, as well as some other travel vaccinations up to date, and acquiring a Ugandan visa. And as I prepared for my departure for Uganda, I met with Dr. Cameron, who had provided me with some very helpful travel documents, and as well discovered that there was a whole community of McMaster physicians who had either been to or still have ties in Uganda that I could reach out to as well. And I found out more about Uganda in terms of religion, and that Christianity was one of the main religions. Over 80% of the Ugandans practiced this religion, and it was central to their daily lives. So it came as no surprise when I read Cure Uganda's Preacher Guide that they had made central to their clinical practice, fellowship, and chapel and devotional time. On arrival to the Cure Guest House, I had a wonderful tour of the hospital, which was not as empty as this was. It was completely full. The wards, the outpatient department, as well as the radiology unit. And then I got to meet the surgical team, who was Dr. Emmanuel Wagoya, Dr. Humphrey Sokechi, and the medical officers who are the equivalent of residents here in Canada, and the clinical officers who support them. And just like here at the Hamilton General, HHS, and St. Joe's, it takes a village to look after a patient. The PICU nurses, the ward nurses, the OR nurses and technicians, the physiotherapists, pastoral leaders, housekeeping, kitchen staff, administrative staff, research associates and assistants, and of course the patient families were central to these children's journey through cure. The day always began in PICU, where every bed was full at every moment in time, with each discharge filled with the next admission. We rounded on the children every morning, and there were some days where there was over 75 children and their parents who spoke multiple different languages to be seen before we can even get to the OR. Becoming part of the Cure team was probably one of the most memorable and rewarding experiences throughout my residency. They welcomed me with open arms, put me to work immediately, and I felt like an integral member of a team that had something to contribute from day one. The large volumes of infectious hydrocephalus that the medical officers saw on a daily basis in the outpatient clinic was a complete eye-opener, because we don't really see this entity as much here in Canada. That led me to read more about Dr. Benjamin Wharf and his motivation to go to Uganda. He was a medical missionary to Cure Uganda during a time where being a medical missionary in neurosurgery was unheard of. He was a complete visionary, overwhelmed by the burden of hydrocephalus, and able to propose a procedure that he had only read about as a financially sustainable solution to VP shunts. He called on his mentor, Dr. Leland Albright, who had performed 20 ATVs prior to his calling, and asked him to spend a week with him to teach him the procedure. And for the first time together, they visualized the effects of post-infectious hydrocephalus and carefully noted in whom the technique of ETV was successful. After finishing rounding on my first day, we attended the OR, and I was given a key to my visiting neurosurgeon locker, and noticed that in the OR that the equipment may actually be a little bit more advanced than we have at the Hamilton General, although definitely the supplies were sparse and the equipment reused multiple times. In addition to supplies that we normally throw away, they sterilize to reduce costs. The chopper shunt was also something that I noticed on the shelves that I'd only heard mentioned by Dr. Reddy, which is an Indian shunt that is low cost. And when I looked into it, found that Dr. Wharf had done a study to find that there was no difference in outcome between the chopper shunt, which is $35 at that time, and the Codman Hakim micro precision valve shunt, which is $650, therefore finding another cost-effective alternative to requiring a shunt in children in Africa. When I read more about Dr. Wharf's contribution to the management of post-infectious hydrocephalus in Africa, I just found that the impact was immeasurable. He found that ETV, or endoscopic through ventriculostomy, is a viable alternative to VP shunt insertion, especially in families who come from a great distance from neighboring countries and low-income families who are unable to return for follow-up. And that endoscopic third ventriculostomy, in addition to coral plexus cauterization, is actually superior to ETV alone, especially where we see that technique fail in infants under 1 year of age. And most significantly, that there is no difference in neurocognitive outcome in children at 1 year between the ETV and CPC procedure and VP shunt insertion. Even now, the burden of post-infectious hydrocephalus remained great, and children all over Uganda, as well as neighboring countries, came to Cure for help. When the infectious burden was high, and on entering with the scope, we were unable to identify any anatomy or visualize because of the cloudiness, we performed a procedure called ventricular irrigation that used warm Ringer's lactate that was infused with antibiotic to irrigate out the infectious CSF. When Dr. Ogoya had done this procedure with me for the first time, he had said to me that he wasn't really sure whether this made a difference. He did say that he had started with one of the medical officers who was having some trouble with getting through ethics and wondered whether I can help with that. And I was thrilled to use some of my research background to be able to help the trainees there. And in collaboration, we were able to get IRB approval. Staying connected at home was also a challenge with the time frame, but I always made time for my little girl. Endoscopic third ventriculostomy and coral plexus cauterization was a procedure that I had specifically gone to Mbale, Uganda to learn. I had 2 weeks learning this procedure, and I was becoming a little more proficient each day with it. And all the while operating on posterior fossa lesions, which is the most common lesions in children, without any power instruments, no microscope, and so I was very glad I brought my loupes, and no neuronavigation or monitoring. And so as a result of that, what I found was that the knowledge of tissue force, neuroanatomy, was unparalleled by these surgeons. The stamina that they had to work for hours in warm conditions was also something I had to become accustomed to. We also saw some pretty bad traumas, and this boy had come in, he came walking and talking, but 7 days after his trauma, he had a dressing over the wound, and the mother said that she brought him in because he wasn't able to keep up with the tribe that he belonged to, which was a nomadic tribe. When we took the dressing off in the OR, what we found that his brain was herniating out through the open laceration that was there. And knowing that he comes from a nomadic tribe and unlikely to follow up, we did our very best to irrigate the adjacent brain, in addition to soak the bone fragments in antibiotic solution, and returned it, as we didn't think that he would return for a cranioplasty. We had reconstructed the cranial vault and sutured him back up. He woke up without any deficits and returned home to his family with prayers from the team that he would not return with a big abscess. Also, with the lack of folic acid supplementation and education within Uganda, seeing myelomeningocele arrive late and also ruptured was not uncommon. As a matter of fact, they operated on so many weekly that the medical officers, who are not even residents yet, were independent in being able to close a myelomeningocele themselves. One of the experiences I was really looking forward to was going with the outreach team to the mobile clinics in northern Uganda. They had just recently gone on a trip just prior to my arriving, and what they do is they attend multiple cities in Uganda where they set up clinics to see either follow-up patients from previous surgeries or new patients that may require Cure's intervention. But then as I was becoming more comfortable with being in Mbale and navigating the city myself and making new friends, as well as becoming more comfortable in the operating room, the global pandemic continued to progress with this announcement from the President of the United States.
Time address to the nation, the ban will be on some travel from Europe to the U.S. starting on Friday.
This is the most aggressive and comprehensive effort to confront a foreign virus in modern history. I am confident that by counting and continuing to take these tough measures, we will significantly reduce the threat to our...
Time address to the nation, the ban will be on some travel from Europe to the U.S. starting on Friday.
Almost immediately, my friends from the United States were asked by their universities to return home. And as I hadn't heard anything in terms of announcemements from Prime Minister Trump and from McMaster University, I was left behind with Abby, who was our local host. As the fear of the unknown grew more and more, the director of Cure asked to come into his office and discuss not only closing the doors to Cure for any new physicians coming, but also to repatriate the physicians that were already there, not only because of border closures, but also for our own safety, given the number of ICU beds that were available in Bali at that time. I, of course, was absolutely gutted that I was going to have to go home early, and after discussion with the director, it wasn't because I wasn't going to be able to do the surgeries where I was progressing, was mainly because I was making friends and learning to work with my new colleagues there and looking forward to the final 2 weeks. In terms of the children, the new admissions and surgeries were reevaluated for urgency, just like it was here at the Hamilton General when I returned, and all outreach activities were placed on hold. The border closures were implemented in a very strict 6 p.m. to 7 a.m. No one out on the street curfew was implemented in Uganda. My return journey home from Uganda to Toronto was long. It was 40 hours, and I had prepared a N95 mask specifically for this journey home. I returned home to my 2 girls, my daughter Anya, my dog Chloe, as well as my husband, and we celebrated my daughter's 5th birthday just with our family. I became more and more anxious about leaving the house the longer I stayed at home in quarantine, but one day looking outside, I saw my neighbor, who has quite advanced Parkinson's and quite elderly, continue with her daily walks around the block, and I thought, if Mila can do it, so can I. And so I ventured out to Costco, where Lysol wipes, sanitizers, and gloves are all out of stock, and realized, it's not just me that feels this anxiety. It's all of Hamilton, it's all of Ontario, and probably the entire world. I came back to neurosurgical residency after my period of quarantine to a completely new framework. We continued to see neurosurgical emergencies with our new PPE armor and supported each other through this, not only with social distancing, frequent hand washing, and PPE use, but also to communicate all of our anxieties and sharing the information that we had at hand. In conclusion, what I learned first and foremost is that global neurosurgery is the long-term collaborations that we form with our international colleagues. While the global pandemic cut short my neurosurgical operative learning opportunities, the relationship that I was able to form have continued, and the experiences in international electives have helped me grow to see the larger picture and how I fit within the global efforts to manage pediatric neurosurgical patients. Thank you. So understandably, I was a little nervous.